So we'll take questions now if anybody's got any.
So I think there's one coming from the floor just over there.
Hi, I'm Shalini again from Matthews Practice in Sheffield. This is a question to Dr. Tawfiq. In one of the slides for integrated primary care FIT ID management pathway, there's a mention on ID anemia, all men and women over 40 need to offer FIT. I wasn't aware, clearly I'm not up to date, but over 40, usually they're perimenopausal and could be menorrhagic. So isn't it okay to give 3-month supplements of iron and then see, or should we still offer FIT for everybody at that age?
A good question. If I'm right, the question was about iron deficiency.
Yeah, iron deficiency, women over 40. According to this, we need to offer FIT. I don't think I've ever done that actually, so this is completely new to me. So.
Yes, that's very good. I mean, that's a pragmatic approach that's been suggested by my colleagues from York, James Turnbull, and it's still under discussion, and that's suggested as to you would probably pick up, particularly if it's in the context of iron deficiency and if you've excluded other causes and if a FIT is positive, yes, you'd want to exclude a low GI pathology.
So when you say exclude other causes, so do we treat iron and then offer FIT or do both simultaneously?
I think you would do both simultaneously.
Okay, thank you.
Question in from the web, just following up on the FIT aspects to Dr. Tawfiq. So if a person has a positive FIT of 10 and then has a follow-up FIT after a washout period of 3 months or so, and that's negative, do they need a referral for a colonoscopy?
I think, again, it's a very good question. It depends on the symptoms. We've already suggested that doing 2 FIT tests is not something that's recommended. If the first FIT was positive and there was definitely a clinical suspicion of bowel cancer, you still do a referral.
Brilliant. Yep. Any other questions from the floor?
Yes,
Professor Sanders.
Really enjoyed your talk. The question I have for you is that there is national prescription data out there that suggests that during the pandemic, patients cashed their prescriptions more for things like 5-ASAs, took them more frequently, and actually upscaled their medication of their own choice. So I don't think that data has been published, but I'm aware of it. And what that tells me, and it kind of ties into your Susie Kane paper, which is that there are issues with adherence. And in fact, one of the unforeseen consequences of the pandemic may be the opportunity for self-care. Primary care is overwhelmed and being destroyed by wonderful organisations like the Daily Mail and perhaps the Tory party as well. So isn't there an opportunity here to enable patients to actually take things into their own hands? You have emphasised over and over again that these are safe drugs. What are your thoughts on that?
Yeah, I think that's a really interesting insight. I totally agree, and I do think that mesalazine is a great example of how patients can self-manage a chronic disease. And I think, if we set them up with, education of how to use them and how to escalate them and how to bring in those topical therapies, then all they really need to come to you for is repeat prescriptions, where they don't have to go up to the hospital park and get a prescription there, but they can direct the prescriptions via your surgeries and their local pharmacy, and they can continue to use them and optimize them. And that may even be the same for these newer steroids every now and then. But that is interesting about the insight from the adherence during COVID. It shows that, and again, it's like when there's a clinical trial, their adherence is 80%, and then it drops off. And I think that's really interesting, and we do have to try and, as hospital physicians, direct them to educational resources, online resources, and we have to be less paternalistic in telling them what to do with these paternal appointments, consultations that we do with them. And yeah, I think that's the key. And mesalazine is a perfect example of how they can do that.
And Chris, you look like you might want to comment on that.
Thank you. I had a couple of observations, if you don't mind. Firstly, with regard to the fit testing in perimenopausal women, it is a challenge. I would support the idea of fit testing, but I'll remind you also from earlier years, data showing that anemia in women is attributed to menstruation when they've got celiac disease. And with David there, we have to remember to look for celiac disease in anyone who's iron deficient and not just attribute it to menstruation. On the current topic, I think David's made a good point about patients being more aware and taking more responsibility. What we've learned is that patients seem to be very happy to be managed at arm's length so long as they know that we're there for them. And remote clinics have worked extraordinarily well. And a lot of patients don't wish to come back to what's Jonathan referred to as a paternalistic clinical system. And I mentioned briefly this pathway we're rolling, the PIFU pathway. The patient is given access to clinic, but we monitor them remotely. And I think that will lead to more interactions with GPs if their calprotectin is up a little or they have some symptoms. But I think we need to be creative and use technology such as the apps that have been mentioned and other resources. The apps, of course, also enable patients to record drug compliance. And I did a study a long time ago with Barney Hawthorne looking at A5 vasopressin and concordance or adherence. And there's a lovely bit of kit where you knew they were opening the pill pot. And as John said, in the setting of a trial, patients will take it reliably twice a day for that particular study, but they don't in real life. Apps, I think, might be a solution to help us with adherence.
Brilliant.
Any more questions from the floor? We've got one here at the front.
Thanks. Oops. Can you hear me? This question for Chris. Great talk, Chris. A question about false positive fecal calprotectins. Everyone's on a PPI medication nowadays. Is that a true sort of elevation of fecal calprotectin with PPIs? And if so, what's the mechanism? And should primary care temporarily stop a PPI, if safe to do so, to allow an accurate fecal calprotectin?
That's a great question. And I think we need to be circumspect, as I said, and be prepared. If you've got a raised calpro in a patient taking drugs that might elevate it, stop the drug for a week or two, and then repeat it. I think would be pragmatic advice there.
Brilliant. Excellent. I think we have one more just over there.
Hi, I'm Ekta, one of the GPs from Sheffield. My question is for Dr. Taufeeq. Yeah. It's regarding the FIT test. So I understand that the false positivity of FIT test increases if there is PR bleeding. But say, for example, if I've examined the patient and there is no other cause identified, what should I do? Shall I wait for a couple of weeks for the bleeding to settle down? Am I wasting time by doing so? Or what should I do in that case?
Yeah, excellent question. You're absolutely right. In a context of rectal bleeding, you wouldn't do a FIT test at all because it's likely to be falsely positive. I know there are some areas in Yorkshire, I think, who do expect FIT tests to be done for every single 2-week referral. We do not suggest that. But if you're still having a clinical suspicion of cancer, i.e. they're older patients and not premenopausal, you would definitely consider a lower GI referral. Yes, I wouldn't wait for the FIT test. And it's very difficult to interpret your FIT result in someone who's got active rectal bleeding.
So in younger patients, I'm okay to wait for the bleeding to settle down and then do FIT test?
Yeah, I mean, yes, in a younger patient, you'd exclude other things. You'd look for anemia, do a good history suggestion to see if they have any other symptoms such as weight loss or upper GI symptoms. You wouldn't just wait for a FIT test.
Thank you.
Can I just quickly ask, I'm seeing quite a few 40 plus with sudden change in bowels to constipation actually. This is despite any dietary changes and being on laxatives. So do they need a referral for colonoscopy? No other red flags?
Yeah.
Thank you.
I think I suppose that's for me. Yes.
It's for anybody on the stage.
Yes, again, the constipation is a very, very difficult topic. It's often, we do know that these patients do not actually have a lot of significant pathology found at the time of colonoscopy. They often have poorer cleansing at colonoscopy as well, so we do not complete the procedure, and the pathology detected is extremely low. So the short answer is, you would probably not refer for a colonoscopy, particularly at that age group, if they had a change in bowel habits, i.e. constipation.
But there may be cases of cancer in those as well, isn't it? I remember seeing something on the news a good few years back, and that lady's only presenting symptom was change in bowels to constipation, actually. I don't know if I'm wrong there.
Yes, I think you're right. Individual cases, you need to look at them sort of in a broader aspect and see if they've had other symptoms, if they've had weight loss or rectal bleeding or family history. Yes, you would consider that. I mean, there are, as clinicians in the secondary care, we could do other tests. Possibly, a colonoscopy is not the best test for constipation, particularly they're very severely constipated.
Thank you.
And Chris, I can see you waving, so I think we'll come to you to close, mindful of the fact that it's really long.
Is the electronic raising of the hand. I would support completely Tawfiq's comment. We don't want to be trying to scope these folks. The yield is incredibly low if you scope people with constipation, and it's a miserable procedure because the bowel prep is poor. I would like to turn the question back to the audience. The question: is this actually people working from home, taking less exercise, and not engaging the things they used to before COVID? I think that might account for quite a lot of people's change in bowel. Certainly in my own clinic, we're seeing those things as explanations. But please don't refer for colonoscopy. If you've got other reasons to be worried, family history and so forth, then maybe a fit is helpful. Of course, this poor young vlogger who has recently entered palliative care for bowel cancer is going to raise expectations and anxieties in patients. And I think that will put a lot of pressure on you in primary care. But the number of people out there who are going to have bowel cancer in that age group is vanishingly small. But be wary about the floodgates.
Thank you. Okay, so I think it's lunchtime, so thank you, Chris, Jonathan, Mo, for those really interesting talks. I believe lunch is outside in the hall. Directions that way. So we'll meet back here. Is it 1 o'clock we're coming back in? 1:30. We've got even longer for lunch. Thanks, everybody.